Hi guys, welcome to my channel where we discuss anything and everything to do with mental health and psychology. In this video we'll be going through KSA 7, which is communication with services and colleagues. And I've got my laptop here, and as usual I recommend doing a split screen and having the KSA guide up while you take notes or write up any ideas from this video. So like the last few videos that I've posted, this is part of the skills section of the KSA. And again, like those videos, what this KSA will need is a self-statement and a reference. And the reference can be a countersigned self-statement. But if you're also applying to BABCP and want them to accredit you, what you'll also need is a training course, and you'll need one of these, not all of them. What you'll need is a training course, and that could be, let's say for example, you can get that learning from your undergraduate, from modules you've done at your workplace or previous workplaces. So it could be through several modules, or it can be one formal training. What you could also do is the criteria for a job that or a course that you've done, and this experience is part of that. So what that means is that it can't be let's say you've had an interview and you've got the job but you never actually do the job. You can't use that as evidence in itself. What you can use is a job that you've actually gone on and actually done that job, or gone on and actually gone on to that course, if that makes sense. What you could also do if you don't have a training course, or you don't have it as part of a job description or a job criteria, what you can do is do self-directed study. So, and then you just have to cite where you got them from, but they have to be almost like official articles, official books. So let's get into it and discuss. The first part is, what are they asking for? So within this section you need to show that you have the ability to communicate effectively. And what that means is that not only do you have the ability to communicate with other professionals that you're working with, within other teams, with other organisations, with other services, but it also means that you can adapt your language and you can communicate effectively with service users, their families, and any other organisations or people that you might need to communicate with to provide effective care. So when I was editing, I realised that I didn't explain why I included service users or clients and family within this essay, because it does say communication with services and with colleagues. The reason why I included them is that you can't effectively communicate with services and colleagues if you don't have effective communication with both service user, client, and with the families. And that's important to highlight. Again, this is a point that you don't have to necessarily include in your essay, but I included it in mine because I feel like the therapeutic relationship, the relationship with the client, the relationship with families, explain how that is the foundation. And if you have clear communication, clear understanding between you as a professional and the client and the service user, you're able to communicate on their behalf with services and colleagues. As well as linking to maintaining effective communication, it can also help, as you'll see, with communicating appropriately and communicating appropriate information, bearing in mind things like confidentiality. It also links to the first and second point that is mentioned within the guide. It helps to demonstrate that you're able to communicate with no clinical jargon or no clinical language, and you're able to translate things into layman's terms. And it shows the broad spectrum, although it says professionals at all levels and non-professionals, which here refers to professionals within different services, but it's also important to just show that you are able to go broader than that and communicate with clients and families. It also links to the third point mentioned within the guide, which is that it facilitates the process, because clear, open communication where there's understanding from the moment that you're speaking to the client and getting their needs met and understanding them, their needs, their families, their social structures, and everything about them, once you have clear communication from there, you're able to facilitate the process. And you can highlight that it allows the process to go a lot smoother. And also bear in mind that there are 2 parts to this video because I gave way too many examples. So this is part 1. So let's get into the statement part of the video. And again, like I've said in my other videos, that this is based on my personal experience of doing the KSA, and it's basically based on what I would put in my KSA. So necessarily, if you don't think any of this is a good idea, or you don't have examples of it, or you don't agree with any of the points that I list, again, you don't have to put them in. This is just to give you ideas of what to write and what I've written in mine, just because writing the essay and getting started with the essay can be quite difficult. So if there's any points that you don't think will apply to your experiences, or again don't apply to you, or you don't think it's a good idea, just leave them out. And if you have anything that I haven't spoken about and you feel like it demonstrates your effective communication, put that in. So this is not to say these are the only ideas or these ideas are the correct ideas. It's just going off my experiences and my statement. And I might just put a disclaimer out there now. Occasionally I will be looking down and looking at my statement just to make this video as accurate and useful as possible. So yeah, now let's get straight into it. So point number 1 is that I highlighted that there's different types of communication. So written, verbal, face-to-face, telephone, especially like video therapy sessions now, or video consultations or assessments, telephone triages, assessments. So it's really important to emphasize that there's different types of communication methods and modes of communication that, especially, it might be useful if you're doing this during the pandemic to highlight, okay, why that's important now, and how it could be, and especially establishing why communication is important. And that's not only to say the modes of communication, but also the different types of communication. So we have verbal communication, body language, we have tone of voice, or the way something's said, or the way words are put together, cultural meanings attached to things. You're saying that you actually have an understanding of modes of communication and you know what communication is and the different types of communication, if that makes sense, and its importance. Do those 3 points make sense? So communication, what it is, modes of communication and what they are, and then third, why it's important. So that was all in my first, almost like introduction paragraph. So if you've done telephone triages, telephone assessments, Zoom appointments, Zoom assessments, face-to-face, any type of communication, just say broadly speak about it. I think also highlighting the complexity of communication, because I think a lot of people, when they interpret this, it's interpreting it as communication written and verbal, but I think it's an extra step going beyond that, where it's really important actually to know the paralanguage that happens. And paralanguage is like language that's not verbally communicated, so it's everything else apart from that. So I think it's important to actually emphasize that, because then it'll go into the other points that I mentioned. So the introduction, just highlight that you're aware of that. That brings me on to the second point, which I'm going to group the first 3 points together because I feel like they all link into each other, because I think it's just defining and showing your understanding. Then the next point is that show that you know when adaptations in communication need to be made. You can show that by highlighting with each individual that you come across, whether that's a professional, an organisation, a service, or a client or a family member, that you need to consider a broad range of aspects of them or you or the situation that make you need to put in adaptations in place or seek external resources. So one of these, or a few of these, might be that you might need to adapt depending on the profession you're communicating with. So you might communicate differently with a nurse, you might communicate differently with a consultant, you might communicate differently with an occupational therapist, with a psychologist, with all these different professionals that work together within a team. So normally these professions are part of the MDT. So even within a team, you communicate differently with different people because their need for information is different. So the information that might be important to a nurse might be very different to information that might be relevant to a therapist, for example. So a therapist might not need to know the exact milligrams of medication or something to do with physical observation. So they might not need to know blood sugar levels. But then again, in a case where the therapist is taking the person off the ward, or that might be something that's important for them to know. But it might not be necessarily the information that always needs to be communicated. So if it's a regular physical observation that's happening that is just part of the routine procedures, therapists might not need to know that. But then a change in mood or a change in risk, a therapist might need to know. Whereas a nurse walking in to hand over, she might need to actually, or he might need to know, or they might need to know everything about the person. Does that make sense? So they might need to know, okay, what are the physical observations? When were they taken? When does the next one need to be taken? When did they last take medication? When's the next dose of medication? Or what's the risk? What are restricted items? What are different people allowed? Or just a small day-to-day functioning of the ward. Someone not working directly on the ward might not need to know that information. Does that make sense? And then when you're talking to a service user or a client, what you might need to do is adapt to their age, their life stage, their developmental age, their cognitive ability, their neurodevelopmental needs, their learning styles. And that you have to explain, okay, why is that important? Because it enables them to understand what you're trying to communicate, and it allows them to be able to, because once you gain an understanding of what someone is trying to communicate, it also gives you the ability to communicate back. Does that make sense? So if they have mental health needs, they might need to know what you're trying to communicate to them, so then they can communicate in return. But then it also might need to be, for example, language. You can't just, for example, if a service user or client talks in a language that you can't speak, it's not that you adapt to that language. Does that make sense? You might actually need to address those barriers within communication by seeking external resources. So seeking a translator, or if there's a therapist or a whatever the intervention or the communication needs to be, or a staff member that speaks the language that they speak, adjusting things and making adjustments in order for them to be able to be seen by someone who does speak the same language. So it really depends on the individual, and that's the key here, is adapting to the individual. So the client or the service user or the professional that you're talking to, because you have to acknowledge professionals have neurodevelopmental needs, they have other needs, and they might learn in different ways. Does that make sense? Especially, like, for example, if you're giving someone the instructions and let's say the staff member or the service user or the client has ADHD and you give them a series of instructions, that's acknowledging they have ADHD. You need to be able to, okay, how would you communicate to someone who has ADHD, right? So giving them a series of instructions is not going to be helpful. So that's not adapting to their needs. Does that make sense? And these don't just apply to service users and their clients, it applies to professionals too. Also, acknowledging situational impact, so the impact of maybe their disorder or their the medication they're on, their mood that day, tiredness, especially if you're on mood medications for your mood or medications for psychosis, might really impact your ability, especially within the first few weeks of taking it, might really impact your ability to understand and communicate. Does that make sense? So it might be if someone is in an acute episode of psychosis and they are finding it difficult to retain information, then it might not be useful to communicate something in that moment and then expect them to retain that information and understand that information that you've given them. Does that make sense? So I'm just going to summarise that because I feel like that was a lot of waffling. So you can adapt to almost like their stable characteristics or almost like static characteristics, where I feel like that's the right word, where it's like, for example, they're neurodevelopmental, or the way they pick up information, they learn information, their culture, their language. Does that make sense? But then you can also adapt to their more fluid or flexible characteristics. For example, their level of tiredness, their motivation, their mood, their concentration, the lack of sleep, medication they might be on, their mental health issue which might be impacting their ability, or general health issues that might be affecting their ability. And to remember that this changes from time to time. So it might be that in one case they might need, let's say for example, pictures or very simple communication of words, but then not to assume that this is a static thing that you always have to communicate to them in that way. Does that make sense? So really just evaluating it throughout the communication, and you have the ability to almost gauge that. So when you're communicating, you can gauge someone's cognitive ability. Does that make sense? That brings me on to my third point, which is the use of clinical language, or what the guide refers to as clinical jargon. And what this basically means is the use of very medicalized or very theoretical terms that aren't used in everyday language. And I feel like generally, if you think about professions in general, each profession has their own type of language. So you should be, as a professional, you should be aware of those languages. For example, if you worked within a nursing team, you might pick up that language. Or if you've worked in a more therapeutic therapy team, or as any other kind of professional, doesn't really come to mind, but like occupational therapy, consultants or doctors might have a different language, nursing teams might have a different language, social workers might have a different language, and healthcare assistants might come up with their own language that it makes it easier for them to communicate amongst each other. And then obviously this varies from different organisations, and whether you're working in physical healthcare or mental healthcare, because they have different abbreviations and different languages. So it's important to be aware of these languages to be able to understand and communicate within these specific groups. But then when you're communicating, you need to be mindful of who you're communicating to. So it's not useful to communicate with clinical language with a service user or with someone who doesn't have experience within that field. Does that make sense? And if you do use that language by accident, because sometimes when you're talking you might use that language, and that might be one of the examples that you used of when you've used the language but then you've followed it up with an explanation. Does that make sense? Or sometimes it might be, for example, you might be communicating a diagnosis or disorder to someone and you might need to actually use the word for that, or a specific type of test you might be doing, or something that, for example, a medication name is something that you have to communicate, but then you also explain it in layman's terms, so very easy and simple to understand way. especially if you're communicating across disciplines, or you're communicating with someone who is not a professional or not part of directly part of the care team. Does that make sense? So you might, for example, if I'm a healthcare assistant, I might use language or abbreviations that I might not write in a referral to, let's say, social work, or if I'm referring to a counselling service. Does that make sense? So it's very dependent on your ability to adapt in a way where, in some cases, clinical jargon completely useful and helps communication, helps understanding. In another sense, you need to know when not to use it and when it can't be useful and it's a barrier to communication. Because in some ways, within a team or within the same profession, it might facilitate communication, but within another profession, it might, or with families, service users, clients, it might actually present a barrier. Does that make sense? So, for example, if you're using the word formulation, you might reword it within when you're working with a client on a formulation. Does that make sense? You might call it something like a map, or call it an overview, or you might actually just use what it is. So, for example, the vicious flower, you might just use the term, okay, this is a vicious flower, and they can clearly see that. Or, for example, you might use the longitudinal formulation, and if you draw it as, for example, a tree, and then you can just say, oh, the tree diagram, and they will understand that. Does that make sense? And this is also to say, when you're using formulations, one of the ways that you might communicate, because this goes back to what you said about communication at the beginning, where it was that communication is not just verbal. So when you're drawing out a formulation or going through a formulation just basically means an understanding of what the person's going through. So within, let's say, for example, therapy sessions, you might sit down with the service user, the family, or depending on how you're doing therapy, and you might share the formulation with them or the understanding of their presenting problems, and you will work on it together so you almost have like a collaborative, consistent understanding of what's going on for that person. So that's very dependent on communication. But for example, if you see Beck's longitudinal formulation, I don't know if, obviously, therapists, you can do your own thing, but personally, I would never use that in a therapy session because it's just way too complicated and confusing. And I feel like it's so overwhelming to have that. So, for example, it's something like having the vicious flower and then turning the vicious flower into a longitudinal formulation, or you just using the tree diagram and using that is a great explanation, because you can just refer to it as a flower or the tree and then it will come to their minds. Does that make sense? But just then adapting language, but then when you're, for example, if you're writing a case study, you might use Beck's longitudinal formulation. And I feel like that's a good example of when let's say you've done a therapy session, or if you're like, let's say, for example, a PWP or a CWP or assistant psychologist, and you've shared a formulation with a service user, that might actually be a good way of demonstrating your communication and your ability to communicate effectively and adapt to the person that you're with. Does that make sense? So to summarise that point, it's to communicate effectively, that you're mindful of abbreviations and the language that you're using, and mindful and in a sense that you are able to be aware of the need and usefulness of using clinical language, and then you're also aware of where it can actually present a barrier to communication. So you know when to use it, when not to use it, and if you are going to use it, you know how to provide explanations in a very simple way. And I think for that, you have to provide 2 illustrative examples, and that might be a good one to present in that. Does that make sense? So to present this point of you being able to adapt language and adapt it in a way where it's not just verbal, it's also written or in a visual form that's easier to understand. Does that make sense? But then that might be very different to someone who has neurodevelopmental needs or cognitive abilities that wouldn't be suitable for. Does that make sense? That brings me on to my next point, which is information should be relevant, concise, and simple. And that's to say that when you're explaining information or providing information, it should be presented in a way that's simple to understand. Even if you're presenting information, let's say within the MDT, you shouldn't make it unnecessarily complicated with just using fancy words for the sake of using fancy words. Because if you unnecessarily add and complicate language or complicate your, for example, waffling, it will take away from the message that you're trying to communicate. Does that make sense? And it reduces the likelihood of that message being understood. And information that's communicated should always confirm understanding, because miscommunication can lead to so many other problems, barriers or issues, and it's better to just address it straight. It will only take you probably a few extra minutes, but it's important. And that's something you might want to highlight, where an example of something being miscommunicated and how it's gone wrong and how you dealt with that. So that might also be a good example that you could use. That brings me nicely onto the next point. As well as relevant, the information should be accurate. So you should always make sure that you write information in an accurate and sensitive way. Although this section doesn't ask for legislation or legal obligations, you can highlight here that accurate and relevant information is actually a legal obligation. So documents and records have to be accurate. And this can contain observing and monitoring patients, their well-being. It could be a way of communicating anything unusual or out of the ordinary for that person. So for example, something related to their physical, mental health, emotional health, and documenting them appropriately, which goes back to me saying that, again, appropriately in terms of not judging them, not stigmatizing them, and recording in as objective way as possible. You can sometimes include your opinion, because sometimes you get a feeling or like a gut feeling about something, but you have to provide a rationale of why you're saying this. Does that make sense? So I might feel like the person is holding back, and that's something that is a feeling that you get from non-verbal communication. Sometimes you might get it from verbal communication and the person might tell you that they're holding back, but you need to justify why you've said that. So you can say, okay, their body language was like this, which indicated to me that they were holding back, or they didn't feel comfortable, or they were reserved in some way. And you need to justify it. You can't just put your opinion in there. So that goes back to, has to be accurate and relevant. And that's it for the video, guys. Hopefully you found this video useful. And as usual, if you have any comments, questions or concerns, please leave them down in the comments. Like, comment, subscribe, all of that good stuff. Anyway, I shall see you in the next video.